Dear Chairman, in my talk, I would like to present you the results of our analysis assessing longitudinal stent deformation during POT. Here you can see my disclosures. Proximal optimization technique is to achieve proper apposition in the proximal main branch, which can be reached by a certain overexpansion within this segment. It's a common belief that this overexpansion results in foreshortening of the stents. However, data about its exact behavior is scarce. The aim of our study was to describe the exact magnitude of stent longitudinal deformation during overexpansion by POT. We performed first in-bench analysis using 3 and 3.5 mm stent platforms from 5 different vendors. They were implanted in bench models with 3 or 3.5 mm distal reference diameter and a proximal main branch segment large enough not to limit overexpansion. We performed crossover stenting with 10, 15 and 20 mm protrusion in the so-called left main segment to simulate different anatomical settings. And incremental POT was performed with 3.5 up to 5.5 mm to demonstrate a wide range of different POT and overexpansion scenarios. OCT analysis was performed after each step to measure stent length in the proximal, in the distal main branch segment, and total stent length as well. Primary endpoint of our analysis was the OCT-defined stent length as compared to its nominal value. In total, we performed 29 bench cases, and to our greatest surprise, overexpansion, so POT, led to lengthening of the stent instead of shortening. Detailed analysis showed that each step of POT resulted in significant lengthening of the stent length in the proximal main branch segment, shown by the red line, for the 3.0 as well as for the 3.5 stent platform, with no change in the distal main branch stent segment, shown by the blue line, suggesting that this is a real absolute lengthening of the stent, not just a slipping movement or dislodgement within the vessel model. Comparing different stent brands, we haven't seen any difference, neither when we compared 2 versus 3 connector designs. Confirming our findings, the best demonstration I have ever seen with proximal stent lengthening was done during a bench case performed by 2 of the greatest bifurcation operators during EuroPCR this year. I would like to invite you to follow this little clip where yellow line shows the proximal stent edge at the beginning, while red line shows the distal stent edge at the beginning, and operators performed here really a perfect potting, large enough to achieve proper apposition, positioning the balloon nicely to the carina as suggested by the panel, as suggested by the commenters, and by this perfect pot, multiple pots, at the end the case ends with a significant elongation, proximally elongation of a couple of millimeters. With these bench findings, we also wanted to understand whether this is just a bench finding or it has real clinical relevance. It can be observed in human cases as well. So we went back to our OCT databases collecting single stent bifurcation PCI cases, which was done by OCT guidance. We excluded all the cases with stent overlap as well as cases where visualization of the stent length was not good enough for analysis. And we measured final stent length based on the OCT, comparing that to its nominal value. In total, we had 36 cases, mainly in left main or in LAD diagonal bifurcation, with a nominal stent diameter of 3.3. These stents were on average post-dilated or potted with +1 mm. And I would like to show you first a typical case from our cohort, the patient with LAD diagonal bifurcation, here the wire demonstrates as well as the turquoise line where the proximal main branch ends. And this 3.0 stent was first post-dilated with 3.5 balloon, and then to correct proximal under-expansion, it was post-dilated with 4.5 millimeter balloon, resulting in marked lengthening within the proximal main branch segment. In the entire cohort, more than 2 millimeter absolute lengthening on average for the cases. How we can interpret it in a clinical perspective? So let's put these findings and try to interpret it within this one single distal left main bifurcation case, where when the stent is placed and has to be corrected proximally with proximal optimization, if the stent is placed nicely to the ostium, then by proximal optimization, we might end with such a proximal aortic protrusion demonstrated by the yellow lines coming the data from our cohort. And it's easy to realize that such protrusion might have relevant clinical and procedural consequences. Where does this elongation come from? Our observations suggest that this elongation comes partially from the pot balloon itself. Namely, there is a marked conical tip distal to the distal marker of the balloon, meaning that the proper carinal position of the marker ends with overexpansion within the daughter branch ostium. And in case of a certain resistance here, calcified lesion, strongly fibrotic lesion, results in proximal slipping of the balloon, a kind of melon seed effect, which stretches the stent towards proximal. So summarizing these findings, we believe that indeed pot is still crucially important to correct proximal apposition, but we have to incorporate in our thinking that overexpansion leads to relevant proximal elongation, as shown in bench and also confirmed in clinical cases. This elongation correlates with the magnitude of overexpansion, and therefore elongation has to be considered when stent length is selected, as well as when stent is positioned. And I strongly believe that the ideal balloon type, as well as ideal balloon position for pot, should be also reconsidered. Thank you very much.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Bifurcation Lesion Treatment Training with Simulation, the Mentice Experience. My name is Peter Zanden. I'm from Gothenburg, Sweden, and I've worked with endovascular simulation for the past 9 years at a company called Mentice. In this talk, I'll try to share with you a glimpse into what I work with, and then more specifically what I, together with my colleagues here at Mentice, have created with the help of Dr. Lasse. I'll try to give you a brief insight to how it looks and why we think it's useful. Then finally, I'll end by sharing my vision of what I believe the future could hold for this type of simulation. For those of you who have no previous experience of my company, I'll try to give a brief introduction to what we do. So since its foundation over 20 years ago, our main product is a real-time free flight simulation aimed at replicating endovascular procedures inside the cath lab environment. When I realized that that is a really confusing way to put it, I instead tried to explain it by asking them to imagine a flight simulator, but for doctors. If you've listened to a presentation by anyone from Mentice in the past few years, we tend to mention what we call the vascular twin. Effectively, this means that we create patient anatomies, pathologies, and scenarios from real-world examples and allow our users to perform a myriad of different interactions with an array of virtually replicated clinical devices. Using a computer and our haptic unit that tracks the movement of clinical devices put into it, you control the flow of the procedure. While our simulation covers everything from neuro to BTK and structural heart procedures, in these last couple of years, my focus has been on the cardiology space. Our vision has been to create a complementary hands-on curriculum to assist the training of endovascular coronary intervention, all the way from med school through angiography, angioplasty, and all the way to the most complex interventions, allowing training in a safe and repeatable way. Most recently, in fact, just last year, I worked together with Dr. Lassen to create the solution that led me to having this talk for you here today. Together, we created a training solution for complex bifurcation techniques. But to allow this project to even begin, a new hardware was developed that allows us to track the movements of a guide catheter with 2 wires and 2 balloons simultaneously, a bifurcation hardware, if you will. Consequently, the Mentice physics model needed to be expanded to allow some very complex interactions. As you can imagine, balloons need to push on one another, stents need to be able to deform, and stent struts need to be possible to pass through and expand individually. And to top it all off, these calculations and estimations need to happen in real time. And while that alone seems kind of daunting, it's not really enough. Being able to practice or rehearse different techniques is useful, but we are all here attending this meeting because we realize it's not that simple. A very real problem is knowing whether or not what you're doing during this training is correct. And that is where the EBC and its participants of these meetings come in. Because you guys have consistently created something amazing, a comprehensive guideline for how to perform different techniques, bringing some semblance of consensus about how to approach different types of bifurcations. Not only that, but they are also constantly evolving and improving these guidelines based on new data and experiments. Well, while I imagine some can read through the material once or a few times and then know it by heart, I would argue that learning by doing might be even more effective. And being able to perform hands-on practice gives an even deeper understanding for at least most people. But learning by doing the traditional way can come at a cost if done incorrectly. However, on a virtual patient, there is no risk, no time limit, and you can repeat the same thing over and over until you master it. So for these reasons, we have integrated the EBC guidelines into our simulation, walking the operator through the steps of correctly performing these techniques. We currently have 4 different cases with automatic built-in guidance that tells and shows the operator how to perform some of the most common bifurcation treatment techniques. The way we have attempted to make this easier to learn and understand is twofold. The built-in automatic guidance give both written instructions and visual cues. These visual cues and instructions cover where to move and position your wires, how to size and position stents and balloons, and how to properly crush and open different stent struts for each of the different techniques, all based on the latest EBC guidelines. We also give immediate feedback if a step is performed incorrectly or if there's something that could potentially cause problems going forward. We do this by constantly measuring how the devices move and how they are placed. In these cases, you can also utilize both IVUS and OCT to look at lesions and the results of your work, verifying stent apposition and expansion. And to add to this, you can also influence the cases in real time. Through what we call the Proctor app, you can influence the flow of the case by creating, scheduling, and triggering complications to occur at will, throwing a virtual wrench into the mix. My hope is that this will be used in low-volume centers to help increase adoption of new guidelines and allow operators to train and rehearse new techniques and gain the necessary hands-on experience while in a stress-free and safe environment. In high volume centers, it enables independent learning to gain repeatable and proctored exposure to these types of complex procedures, thus freeing up proctor time that would otherwise be required from a senior physician. While I hope that most of you will be intrigued by this already, there is plenty of room for improvement and further development. I want to take this opportunity to share my and some of my colleagues' vision of where we think this type of simulation is headed. But to understand where it at least could be heading, I want to first show you an example of where it is currently at and what we're working on. For structural heart, we have an application that we call Cardiac Sculptor. It allows operators to recreate specific patient anatomies and perform rehearsal operations on the real patient data. Upon using the solution in Stockholm during mitral valve repair cases, they showed a reduction in procedure time of 3 hours down to 2. Clearly, it helps them to discuss the upcoming procedure in real terms and allows them to easier identify possible difficulties and complications, and thus being prepared to tackle them during a live operation. Effectively, it has allowed them to streamline the procedural workflow before the patient is even on the table. Speaking of tables, in order to improve the realism of the training, our simulators can be placed in and connect to several Philips and Siemens angio suites, utilizing real tables, controls, C-arms, and screens. And I believe that the combination of cath lab integration and patient-specific simulation is where we are headed. I envision that simulation can become even more integrated part of endovascular procedures. What if next to your patient fluoro screen, you also have a simulation screen that showed the virtual twin of that patient with the same anatomy, same pathology, and as you move with your devices inside the patient, the simulation follows along automatically. At first, simulation could be used to practice certain steps before you do them, perhaps help you find optimal angles for your C-arm or hint at areas that might need a closer inspection. The more realistic this type of simulation becomes, the more things it can do. Perhaps it starts giving you hints on sizing, where to go with your wire, and hint at what catheter could gain you the easiest and most secure access. At the least, it could help reduce fluoroscopy time and contrast use, but it could also help gather data from previous procedures all over the world and put that knowledge into your hands. With the advent of robotic solutions, eventually, they won't necessarily be hands at all.
Dear Professor Levard, thank you for the invitation to present at the EBC 2021 meeting. The title of my talk is MicroCT Analyses of Stenting Performed within Reanimated and Fixed Human Hearts. You can see one of those reanimated hearts on the video on the left. EBC members performing stenting procedures within the Visible Heart Lab. And then the lab is located in the basement of the Mayo building. A lot of history in this building. It's the place where some of the first open heart surgeries were performed anywhere in the world. And in the labs themselves is the place where Earl Bakken, the founder of Medtronic, brought the first wearable pacemaker and did a preclinical study back in 1958. So we do really translational systems physiology in the lab, large variety of different studies, but the heart of the lab is the Visible Heart Project itself. We started in fall of 1996, 25 years ago, and this was a collaboration we started with Medtronic back in that period of time. We've had the unique privilege in the lab to reanimate human hearts. Since 2000, we've reanimated 91 human hearts, the last one several weeks ago. So in the video here, you can see the heart is brought into the lab. We'll cannulate it, and basically it's all reanimated with a clear perfusate. So the cardioplegic buffer is flushed out. We'll deliver a shock. These hearts will go into a native sinus rhythm for some 5 to 7 hours. And for the first 2 hours of these reanimations, we dedicated to multimodal imaging to really collect all this amazing functional anatomy and then put this on the free access website. After the collection of this anatomy, basically the grad students who are doing studies on reanimated swine hearts can do work on reanimated human hearts, making their work translational. And then after that, we're doing a lot of device placements within these reanimated human hearts, including various stenting and TAVR procedures. These hearts are all preserved, as are hearts that come to the lab that we can't reanimate. And we're using an apparatus put together by Emma Shimstock, one of the current PhD students in the lab, where you can do differential pressure loading within the heart and using formalin, and it'll fix these hearts at an end-diastolic shape and keeping the chambers, aorta, arteries, all patent while closing the valves. These specimens then can be used for a variety of different studies. They can just be, used for MRI imaging, CT imaging, MicroCT imaging, or just study visually with, your own eyes and have a privilege to hold them in your hands. So here's one of the studies where we took one of these fixed hearts and did a stenting study in it. So we set up the lab, we can do multimodal imaging here. We can look at direct visualizations of the stenting being performed. We can see the ostia of the left main there where the stent is being deployed using fluoro and OCT and watching each step of the procedure. The hearts then are brought over to a MicroCT scanner. This is a X5000 North Star instrument scanner over in Geological Sciences, which is the other side of the University of Minnesota campus. So here's Tommy Valenzuela, or Dr. Valenzuela. He just finished his PhD a few months ago in the lab, performing one of these studies in the scanner. This was a bifurcation stent, 2-stent, looks like a Culotte procedure. And then you're using the right energies and intensities, and you're getting down to 10 to 20 micron resolution. You can then take those DICOM files, put them into imaging software, using materialized mimic software, and make computational models. So we've used both reanimated hearts and perfusion fixed hearts for a variety of studies as well. So in this study, we looked at a left main provisional stenting. We used 7 human hearts, and basically on the left video, you can see a procedure done in a reanimated heart, and the one on the right is a procedure performed in a fixed human heart. And again, all these hearts are taken afterwards and used for MicroCT studies. Or you can do this step by step. And in this study, we did a step-by-step Culotte bifurcation technique using EBC guidelines. And part of the steps, we had EBC members performing these. And so one step, we just wired it. Then we deployed the first stent. Then we did a final pot. And then we put in the second stent. And you can see in the lower image below, the reconstructions of all the models from the MicroCT. Good. We've also performed post-TAVR PCI in the lab. We had Dr. Brazoda and Lawson's in the lab when we did one of these. And so basically we've got key opinion leaders coming to the lab. You're getting direct visualizations of the process. We'll fix these hearts afterwards. MicroCTM, make the computational models. We can 3D print these, do fly-through videos like this using Unity software, or you can then put these on the Atlas website. The Atlas website is a free access website. There's over 5,000 videos and stills on there. And again, it's free access because we're gifting all this knowledge back to honor the gifts we got of these human hearts. So if you went to the device tutorial, looked up stenting, you'd see many of the videos performed in the lab relative to bifurcation stenting. You can also see some of these videos on the bifurcation exploration site that Medtronic hosts. Thank you very much.
Hello everyone, I am very happy to meet you again and have a chance to make a presentation. This is my disclosure. Today I'll show the three parts like this. First is lesson from the bench study and pathology. This is a bench study in the left main bifurcation model. If we implant 3.0 mm stent according to the distal diameter and do not perform POT or KVI, the outer region where the stent strut that is surrounded by a yellow circle cause incomplete apposition, it can be seen that the blood flow dropped extremely. Furthermore, on the gelled circumflex ostium, it is easy to see that the blood turbulence and drop are occurring on the back of the strut. If we choose a 4.0 mm stent according to the diameter of the proximal side and do neither POT nor KBI, the area of incomplete apposition of the stent will decrease and the blood flow reduction area will also decrease. On the other hand, in gelled circumflex ostium, it is easy to see that turbulent flow and decrease of blood are occurring on the back of the strut as in the previous result. Let's all think, what do the result of this bench study mean? The pathological findings reported by Dr. Mori and Professor Birmani in 2018 showed us a very impressive answer. Thrombosis in stent implanted left main shaft and left main bifurcation are extremely infrequent. However, once they occur, they can be fatal. It shows that this thrombosis can occur for a long time after treatment, regardless of the version of DES, and that their main cause is stent incomplete apposition on the left main shaft or gelled side branch ostium. Again, even with the frequency of stent thrombosis in left main is low, once it occurs, it is directly linked to the sudden death of the patient. Therefore, it must be avoided as much as possible when using a stent. This fluid visualization test showed that there is a marked slow flow between the vessel wall and the incomplete stent apposition area, and turbulence and slow flow always appear on the back of the gelled strut at the side branch ostium. So we come up with some requirement. Eliminate incomplete apposition of stent. Reduce the deformation of the stent on the main vessel side. And reduce gelled strut at the side branch ostium. Therefore, we compare the incomplete apposition volume of the Culotte and DK crush method, which are also used in the two-stent technique. On the left is a flow chart of the Culotte procedure. On the right is a flow chart of the DK crush. For the same left main bifurcation model, Culotte stent and DK crush stent were performed 6 times under the fluoroscopic situation using synergy. The left is Culotte and the right is the whole image of the DK crush. The part of carina painted in green shows the incomplete apposition. The area of the blue is the incomplete apposition of the left main shaft. In the Culotte group, the green triangle shows the incomplete apposition volume in the carried part of each model. The DK group, there is a considerable variation in the result. Compare the Culotte stent group, DK crash group were higher in all incomplete stent apposition volume in the lateral wall and carina. Next, the effect of the difference in pressure on the stent apposition was evaluated. In the high-pressure DK group, there was considerable variation in the result too. From these results, consider how to get better result. Here is a result of comparing the three groups. The stent incomplete apposition volume on the lateral wall can be reduced by changing the pressure at the time of crash or final KBI. It is recommended to reduce the area of strut triple as much as possible. Consideration should also be given to the stent design. Choosing high pressure indicates tend to reduce the stent incomplete apposition volume in carina. As another important factor, the guide wire recrossing point is greatly involved, which is still an unsolved problem. My conclusion: stent thrombosis in left main is directly linked to patient death and is an event that we want to eliminate as much as possible. The key point are stent incomplete apposition at the left main shaft and jailed strut at the side branch ostium. Each stent implantation method has advantage and disadvantage, and there are still many points that need to be improved. In particular, the recrossing point of guide wire is very important. However, it is not completely controlled, and it is one of the remaining important issues. Thank you very much.
Dear Chairman, thank you for invitation to present at the EBC 2021. The title of my presentation is Elliptical Stretch of the Cause of Side Branch Compromise After Main Vessel Stenting in Coronary Bifurcations. The rationale of our study is that despite that there is some refinement about the mechanism of side branch osteocompromise after stenting bifurcations and the two working hypotheses, that is plaque shift and carina shifting, there is still some debate about the mechanisms leading to osteocompromise or osteostenosis after main vessel stenting. We propose a potential mechanism of side branch compromise that is osteodeformation, resulting in reshaping of side branch vessel ostium from circular to osteoellipse after stenting, and this changes the osteovessel area, which as a consequence change the volume flow in the side branch. In this cartoon, we demonstrated the possible changes with stenting. When the stent is placed, there is a lateral stretch of the ostium, the side branch, in the direction perpendicular to the plane of bifurcation. This is caused from carina shifting and from the deformation from the stent at the very ostium of the side branch. Those changes were demonstrated from us in elastic bifurcation models several years ago with stretching at the lateral points of the side branch osteum, and also those changes were demonstrated by OCT imaging in bifurcations stented from several groups. The objective of this study was to explore the theoretical effects and to make a correlation with these possible deformation effects with FFR, which is a current standard for assessment of stenosis severity. We proposed three possible changes of the side branch osteo woman after main vessel stenting. The first one is circular to circular after stenting main vessel. This is a circular to circular osteo shaping in the side branch osteum. The second one is circular to ellipse, where the perimeter of osteo woman is constant and only the shape is changing. And as alternative, we assume that the osteo woman is elliptic at the beginning before stenting, and it goes much more elliptical after stenting. And these are formulas which we used for our theoretical calculations and predictions, and this is the main result from the theoretical calculation. As you can appreciate, with increasing the stretching coefficient, which is the ratio of the major ellipse axis to minor ellipse axis, there is actually decrease in the area of the ellipse, which results in increase of the area stenosis at the osteum, just because of changing the shape of the osteum. However, this area change and this increase in area stenosis is less, and this is quite significantly less than the case where the circular osteo area stenosis is assumed. We used for verification our patient cohort from Fiesta study, and we used 49 patients to compare the results of FFR after stenting main vessel, and we compared two groups. These are patients without side branch predilatation and patients with side branch predilatation before stent placement in the main vessel, because these are probably representatives of the 2-hour assumptions with the circular to elliptical change and elliptical to elliptical change in our theoretical analysis. When we made the correlations, there was practically no significant difference in case where the area stenosis was assumed as circular shape. There was no difference in FFR positive and FFR negative patients. However, if the area stenosis at the side branch osteum was calculated as ellipse with our two different assumptions, there was a significant difference no matter what type of assumption was made between the groups with FFR positive and negative results. And in both cases, when the area stenosis was calculated as ellipse, there was a much more severe osteo area stenosis than in cases with functionally non-significant stenosis. In conclusions, the elliptical osteo transformation of side branches after main vessel stenting is a probable mechanism of side branch compromise. The osteo area stenosis calculated based on this assumption correlates better with physiological parameter of severity, FFR, than area stenosis calculated based on traditional circular formula.
Dear Chairman, Thank you so much for inviting me to the European Bifurcation Club. This is the title of my talk, Local Fluid Dynamics in Patients with Bifurcated Coronary Lesions Undergoing PCI. These are my disclosures. This is the design of a virtual clinical trial we ran to compare different bifurcation stenting techniques. We have 120 patient-specific bifurcations covering the entire spectrum of bifurcation angles and disease complexity. Each bifurcation is computationally stented with 4 different techniques, 1 stent technique or 2 stent techniques, Culotte, decay, crash, tap. Then for every bifurcation stenting technique, we calculate biomechanical factors like fluid and solid shear stresses, fluid stresses, as well as stent morphometry parameters like strut, apposition, expansion, and so on. And then we create an atlas essentially of bifurcation anatomies and stent simulations. The whole goal of this virtual clinical trial is to identify groups of bifurcations which are best treated with specific stenting techniques. Let me get into the specifics of this study. This is the platform, the computational stent platform we use to simulate computationally those techniques. We start with merging angiography with OCT to 3D reconstructed bifurcations. Then we assign Plaque-specific material properties coming from OCT. We enter in the system and the platform realistic stent designs and balloons. We run the simulations, the computational simulations of 4 different techniques as I described, and then the outcomes of the platform of the study is stent morphometry as well as stent biomechanics. A close-up of our methods here, the reconstruction of the lumen, then meshing of the lumen, and also assignment of realistic plaque stiffness. We identify by OCT the configuration, distribution of different plaque constituents in the 3D reconstructed wall, and then we translate this to patient-specific plaque stiffness. Here you see different OCT frames along the reconstructed wall and how they correlate with patient-specific wall stiffness. Then each anatomy is stented computationally with 4 different techniques: Provisional, tap, Culotte, and decay crash. Following the steps we published in our recent white paper by the EBC. This is the Provisional, TM protrusion with a metallic neocarina. Again, the only thing that changes in each bifurcation anatomy is a stenting technique. Culotte and decay crash. Then for each anatomy, for every technique, we calculate with CFD the flow distribution across the stented segment. And you can see here the flow distribution with the Provisional technique, with the TM protrusion, Culotte, and decay crash. You appreciate the flow acceleration across the stented segment with diastole. Also, we calculate the shear stress distribution across the stented segment. Again, we talk about the same anatomy, the same bifurcation anatomy, stented with computational with 4 different techniques so that we can compare apples to apples and head-to-head comparison between different techniques. And then we can have like a bigger close-up, focus on the strut level. Here you can see in a decay crash technique, the distribution of shear stress on the main vessel, side branch, at the carina. You see the flow acceleration around the stent struts at the carina with diastole. Even we can see the crashed part of the stent, this double layer stent at the distal main vessel close to the side branch osteum. Also, we have the opportunity to cut across different locations of the stented segments and get to see how the flow is distributed there as well. Each bifurcation anatomy then is assigned different zones which cover all the area from the very proximal segment to the distal side branch, distal main vessel. And in each zone, for every bifurcation technique, we calculate biomechanical forces and factors and stent morphometry parameters. This way, we have the opportunity to compare head-to-head different bifurcation techniques in the same bifurcation geometry in the same particular zone. And this information is very important because it can give us the opportunity to identify what is the technique, the stenting technique that gives us the best performance, the most favorable performance in an individual bifurcation anatomy. Not only we compare different stent techniques, but also we compare different post-dilatation techniques like pot versus kissing. That's a study which the data we use come from the ProPot study, where 120 bifurcation lesions coming from patients were post-dilated either with POT or kissing balloon inflation, 60 with POT, 60 with KBI. Using our sophisticated algorithms, we 3D reconstruct the implanted stents using OCT. And then here is an example of the 3D reconstructed stent by OCT in a patient with a POT and a patient who had post-dilatation with KBI. Again, those are patients who had one stent technique post-dilated with either POT or KBI. And then we calculate the flow distribution and the shear stress in POT versus KBI. Here we talk about different patients, different geometries, but definitely we have the opportunity to compare the flow distribution between two different post-dilatation techniques. So with that, I would like to thank our funding sources for funding from federal resources, from industry and philanthropy. A big thank to my group, the world-class engineers, MDs, and vascular biologists who are behind all those sophisticated studies. And I would like to open this to discussion. Thank you for your attention.